So good afternoon, everyone, and thank you, Dr. Clark, for that kind introduction. It is a real honor for me to join you all today, and I was sharing with Dr. Clark how an attorney got into this space. It's actually interesting. I set out really wanting to go into healthcare administration, was going to do an MPH or an MBA, and during one of my internships, I was in South Florida at a hospital in Fort Lauderdale. I was in the emergency department, and I witnessed something that was really life-changing for me. It was a woman, she was from Haiti. She did not speak English, and she was just in tremendous pain and agony. You could see it on her face. She was getting anxious. She couldn't communicate with the triage nurse. And the triage nurse, interestingly enough, called for another nurse. This other nurse was also black, and this nurse was from another island in the Caribbean. Well, the triage nurse thought that because this woman had an accent, well, she obviously is from the same place that this patient's from, and so they tried to put them together to communicate. It actually blew up with the nurse now getting upset. Why did you bring me here? I don't speak French Creole. I speak English. I might have an accent. And I said to myself, my God, I wonder how many times this happens in hospitals throughout our country. Because we all know that every second is extremely precious when you're taking care of patients. So that for me was the catalyst that said, wait a second, I'm wondering what I can do to effect some changes, not only here in the hospital in terms of policy, but on a larger level, at a wider level in terms of nationally. And so that got me thinking, gee, I think health law is the route to go. And I'm curious, anybody interested in maybe going to law school? Any health lawyers, future health lawyers, at least one? Okay. Any MPHs, public health folks? Okay. And then how about physicians, MDs? Okay, great. Well, we need everyone. And I am definitely a proponent for transdisciplinary collaboration, and I think this is exciting. And I commend the NIH Academy for giving this issue, the attention that it deserves, because it really is a key component of the transforming journey of health reform that we're embarking on. So today, what I want to do is discuss the progress that has been made to advance health equity via laws and policies. And we're going to look over the last 32, 33 years. Then we're going to discuss provisions of the health reform law that will have the greatest impact on vulnerable populations, discuss some of the challenges that we've been witnessing or observing in terms of trying to advance this health equity agenda, and then discuss opportunities for all of you moving forward. So what's the impact of disparities? This is what we needed to convey to lawmakers when they were putting together the health reform law. So as folks, if you might recall during the negotiations, what the various committees did was to actually convene subcommittees or working groups. And no one wanted to look at this issue of health disparities. But we said, wait a second, if the Obama administration is going to call this comprehensive health reform, if the health reformers or the proponents of health reform in the Senate and House are going to call this comprehensive health reform, well, comprehensive should include a health equity agenda. And here's why. So we had to make the case. There are 83,000 racial and ethnic minorities that die per year. When you talk about other groups, the disability groups, the LGBT groups, others, et cetera, that number I'm sure is way larger. In terms of the costs, what we were having a difficult time trying to convey in terms of making the case was the cost, the economic burden that health disparities has on our nation. Well, at that point, during the negotiations in the fall of 2009, we got the Joint Center for Economic and Political Studies and the Urban Institute to do two studies. And what they found was astonishing. I think the numbers were a lot more frightening than we had imagined. They actually figured out that we are spending $300 billion a year in both direct and indirect costs. So that was the aha moment we needed. That was the statistic that we needed to convey lawmakers to continue with the agenda. So first, the moral argument was working for us to an extent. Several months after, in the fall of, in September 2009, nobody wanted to hear that folks are dying because of disparities. And so we got these figures from several healthcare economists at Johns Hopkins, and we were able to continue pushing this agenda forward. Again, we also made the case that health disparities are not isolated issues. They're really the result of interactive factors, environmental, social, et cetera. And what we wanted to keep pressing on lawmakers was the fact that negative health outcomes and disparate treatment in healthcare impact the economic and social vitality of communities, because if people are sick or they're dying younger, they're not able to contribute. So what did we do to continue pushing this agenda? The World Health Organization in 1985 actually said that health equity implies that ideally everyone should have a fair opportunity to attain their full health potential. 23 years later, and it was interesting, right before we started negotiations over the health reform law, they came out with another study from their Social Determinants of Health Committee. And in there, they talked about how health inequities are really intensified by political, economic, or social influences. And it's something that we as a group, the 300 organizations that you heard about earlier, really believed that oftentimes what we've observed is policy, public policy and laws have been a driving force for many of the inequities that we observe in communities across our nation. But we also believe that public policy can be that driving force for helping us appropriately address these issues. And so with that in mind, we really pushed this agenda with both Republican and Democratic lawmakers. And over the last 32 years, this issue, it's a nonpartisan issue, really having tremendous bipartisan support, and you're going to see as we go through the timeline here. But in 1983, many of you might recall that the Secretary of Health and Human Services, Margaret Heckler, in 1983 realized that while the overall health of the nation had been improving, the health of racial and ethnic minorities actually was alarming. The statistics were extremely alarming to her. And right when she figured that out, there were several health equity champions that said, you know what, we've got to push her. We have a sensitive person, a person who's sensitive to this issue. We need to come up with a report that spells this out for her. And so some external champions for health equity created a report, or actually funded a report, gave her the results from that report, and that's what she used then to set things in motion. She then organized her own task force internally at HHS to study this issue, and she got some of the best and brightest minds to come together around this. Well, out of that task force was the Office of Minority Health that was established at HHS headquarters. And from there were also additional programs that were established because of her efforts. Well, in 1990, we also had the second African-American Health and Human Services Secretary, Dr. Lewis Sullivan. And Dr. Sullivan was one of those external champions that had pushed Margaret Heckler during the Reagan administration. So Sullivan, actually, when they were creating the Healthy People 2000 agenda, says, you know what, I'm going to actually be bold and include as one of the priorities reducing health disparities. Had never been done before. He got a lot of backlash from folks internally, as you can imagine, but he still pushed ahead and said, nope, this is an issue worth considering, and we're going to actually include it in the agenda. Well, around that same time, Sullivan worked with Congressman Stokes, and you might have seen his name, Louis Stokes' name, on one of the buildings here at NIH. He was the first African-American to get a seat on the powerful Appropriations Committee, and from there he pushed the agenda. And he had worked several years now after Margaret Heckler had convened the task force and they had established the Office of Minority Health. He was extremely concerned that the Office of Minority Health could just be eliminated through executive order. And so he and other folks in the Tri-Caucus, do any of you know what I mean when I say the Tri-Caucus? Have you heard that term before? No? Okay, so the Tri-Caucus really are the three racial and ethnic caucuses in the House and Senate. So you're looking at the Congressional Black Caucus, the Congressional Asian Pacific American Caucus, and the Congressional Hispanic Caucus. And sometimes it includes the Native American Caucus. So these groups really pushed together and said, you know what, let's create a pretty comprehensive legislation around this issue. We've got to codify the Office of Minority Health. We've got to codify the Office of Minority Health here at NIH, et cetera. And that's what they did through the Disadvantaged Minority Health Improvement Act of 1990. That was huge. It was huge because it had taken 100 years to get this type of legislation passed. So post-Reconstruction, there was only one law that was ever passed that helped the newly freed slaves. That was the Freedmen's Bureau that actually said we're going to provide some level of medical care to these newly freed individuals as well as refugees, so those who had fought in the Civil War. And interestingly enough, in order to pass that law, they could not show preference to one racial group versus another. That was the same tactic that they used post-Reconstruction in the 1860s. They used again in 1990 to pass this bill. So very, very interesting stuff. And we can go into more if you're interested. At that point, the Tri-Caucus realized, along with Senate champions, Senator Kennedy and others, that wait a second, that bill, the Disadvantaged Minority Health Improvement Act, was really small. It didn't quite get to it. Yes, it appropriated some funds to research these issues, but we needed to do more. We needed to establish centers of excellence through the NIH at various universities to really study this in a comprehensive manner. And that was the law that passed by the Clinton administration in 2000, the Minority Health and Health Disparities Research and Education Act. And many of you in health disparities, if you recall, the Agency for Healthcare Research and Quality publishes an annual health disparities report. You guys know about that? Yes? Yeah? Okay. So that is a result of this law. The Institute of Medicine's Unequal Treatment Report, that landmark report,